It's a real pleasure to be talking to you today, and it's nice to see some familiar names on the delegate list, and I hope you're all doing well in this very difficult time. So yeah, I don't know about you, but at the start of this year I felt as though 2020 had quite a nice starting blocks yet, but hopefully we're getting there. So just wanted to talk a little bit about the recovery of elective knee surgery and where we're at the moment. We need to be careful regarding the second peak, and obviously the first thing to consider is do no harm. So there's a lot of things in place at the moment in terms of gold hospitals and green pathways to ensure that we're doing the right thing at the right time, but we're slowly getting there. This recent guidance that just came out last week is definitely going to help us. This is regarding PPE in theatre practice and aerosol generating procedures, and the BOA have now decided that the risk in terms of orthopaedic procedures is actually very low in terms of transmission. So this will likely really help us move forward back to where we were, so that we're not having the rigmarole and the problems of wearing PPE. And this is coming in now as we speak, and this is really going to help us. We then need to think about prioritising cases. Now, obviously, over the last few months, we've been dealing with priority 1 and 2 cases, and we're really interested in these priority 3 and 4 cases, which is our routine elective practice, such as ligament reconstruction and routine joint replacements. And patients with chondral problems probably come within these brackets, either a 3 or a 4, depending on whether it's an acute osteochondral problem or a chronic issue. And the other thing to consider is the patient risk. Unfortunately, a lot of the patients that we're going to be discussing today, and I'm going to go through some cases later, do fall into this low risk category, because most of our patients with the chondral pathology we're dealing with are under 65 and have very limited risk factors, and most can also be done as day cases. So this will certainly help us in this cohort of patients. Now, the patients that we talk about are very much within this treatment gap. Many of them have already had injections, brace therapy, and even an arthroscopy. And then there's quite a big step up into the more joint modifying procedures, such as osteotomy, partial knee, or even total knee replacement. And this is very much a clinical treatment gap. The patients are much younger, between the ages of 35 and 55, very active, employed, and they really want to get back to their activities as soon as possible. And I was at a conference at the end of last year, Tim Spaulding's conference, and Alan Getgood from Canada gave a really good talk on his joint restoration philosophy. And before thinking about the chondral resurfacing options for us, we really need to think about the alignment of the patient, whether or not they may need an osteotomy, the stability of the knee, and as to whether or not they might need a ligament reconstruction, the state of the meniscus, if they've had a previous subtotal meniscectomy or a partial meniscectomy. And then once the mechanics of the knee have been sorted out, we can really focus in on what we can do in regards to the biology and any resurfacing options. And I think that Alan's slide here is a very good take-home message for that joint restoration and preservation. I'm going to base the talk on this paper from 2015, which was a consensus statement from just over 100 knee surgeons in the UK. And it was really a survey as to how cartilage defects were being managed within the UK population. And it really comes down to 4 different categories. So we've got bone marrow stimulation techniques such as microfracture, which we'll all be familiar with, osteochondral grafting, which can be either autograft or allograft, cell therapies, which really fall into the bracket of ACI, and then focusing resurfacing implants, which we're going to focus on today. This was published in the Knee Journal in 2015. Now, microfracture is still recommended for smaller lesions less than 2 centimetres squared in size, but there's now good evidence that this fibrocartilage that generates does then degenerate after 2 years. And certainly that's my personal experience. And the number of microfracture cases that I'm doing now has really plummeted over the last couple of years, just based on my own outcomes and my own findings with my patients. And it's still something that I offer, but I very rarely do. It can also muddy the waters for future treatment options in the future as well, such as ACI. So although it is still within our repertoire, it is not something that is increasing in practice really. Now, the osteochondral option, this is a case of mine that I did a couple of years ago. This is a window cleaner with a massive osteochondral lesion there you can see on his medial femoral condyle, often known as mosaicoplasty. And my thoughts of this are that it's still a good option, but it's probably better for small and localized areas where you can just use a single osteochondral plug. It's quite an invasive technique, and it can be painful, and the rehabilitation is often quite prolonged, between 6 and 9 months. So it's still an option there, but the numbers are low, but it's still on the NICE guidance in terms of a recommended procedure. But I think the indications are quite small for an Oates procedure. Another option is an osteochondral allograft. Now, there's a great deal of interest in this at the moment, and Bill Bugby, who's on this photograph here over in San Diego in the States, has got the largest series in the world, published over 600 cases in 2016 with excellent results, particularly in patients with avascular necrosis and osteochondral lesions. Results were less good in patients with arthritic change and kissing lesions. And Martin Snow, shown here on the right side down in Birmingham, has also got great experience of this. But what we found is that this is mainly an option for very large research centres with big research budgets, because there's a significant cost implication with this type of surgery. Funding is an issue, and there's sometimes a delay in treatment as well for the patients, because we have to find a size and shape match. It's something I'm interested in, but at a general district hospital level, it's often difficult to actually get your hands on this product, and it's difficult to negotiate. But I certainly think it's a good option for some patients. Now, ACI, there's plenty on the NICE website about ACI, and it's now recommended that if a patient has had previous surgery, such as a microfracture or chondroplasty, then really ACI is no longer recommended. It's also recommended for defects over 2 centimetres squared, and they've stipulated it should certainly be done in a tertiary referral centre, like a research centre with a good evidence base behind it. And again, at the bottom of the slide there, you can see the main limiting factor with ACI is, again, cost. And when NICE looked at this, they were looking at an average of £16,000 per patient per episode, which is just not doable in many of the NHS trusts and CCGs up and down the UK. So I think it's a great option, but perhaps only in certain centres. When we look at focal resurfacing implants, there are various implants on the market. These are two well-known implants. One is the Episealer product, which is from Episurf Medical, which is a shape-matched implant, usually based on a patient's MRI scan, and it's a metal implant with a press-fit technology. And the Hemicap is a similar procedure made from Arthrosurface. These are purely metallic implants. And there's various publications out there for these, often with very small patient cohorts, some of which have been associated with bone loss and loosening. And the numbers there are quite small in the literature. Today I wanted to talk about the BioPoly, which I was introduced to through Hospital Innovations almost 6 years ago now, down in Bristol. And this is a photograph from a cadaveric specimen with a biopoly in situ on the medial femoral condyle, and I thought this was quite interesting. It was certainly new material science. It was a very simple technique, innovative, and may offer some of my patients a different option in what is a fairly limited group. The device itself is a combination of ultra high molecular weight polyethylene, which is impregnated with hyaluronic acid, and this gives us a more hydrophilic substance, which has got excellent wear potential, and the stiffness of the device is much more akin to normal articular cartilage, whereas a metallic implant is around 16,000 times stiffer. So it's certainly got great potential in terms of wear characteristics and longevity when compared to some of its metal counterparts. The indications for the procedure, well, that you can implant the device onto the medial or the lateral femoral condyle. There's a now patellar implant and also a trochlear implant. But it's important to remember for the femoral side, it's only for monopolar disease. So if they're heading towards a uni and they've got tibial involvement, then it's not indicated. The size of the lesion should be less than 3 centimeters squared, and it should be really well contained by good cartilage, but similar to the image there that you can see on the MRI scan. Depth is also important, and it needs to be less than 4 millimeters from the articular surface. So it's very much a surface, a resurfacing procedure rather than a bone grafting procedure. The contraindications we just mentioned there, uncontained defects. We talked earlier about malalignment and laxity that may need to be corrected prior to surgery. So it may need to be done in combination with a high tibial osteotomy or an ACL reconstruction or a stage procedures. And we really recommend a meniscus over 50%, so not patients that have had a subtotal meniscectomy. And they're really the contraindications. In terms of the technique itself, it's very simple. The scrub nurses find this very, very nice because the kit comes on one tray. This is the femoral condyle kit, and it's an uncemented device with a porous coating and a press fit. And you can see there the instrumentation is very simple. When we're implanting the biopoly, we aim to get 0.5 millimeters of implant recession, so just beneath the surface of the joint. And this is very important to prevent point loading and an impingement of the device and symptoms of catching and locking in the knee. So we're always looking to recess the implant by 0.5 millimeters. Now the patella device is slightly different. It's not metal backed, it's a cemented implant, and there's 2 different sizes in terms of thickness and diameter. And these are really for isolated facet resurfacing, either on the medial or the lateral facet of the patella. And again, it comes in a separate tray, very simple and very easy to use. Now, my experience so far in the last 5 years of the biopoly, I've done 31 surgeries, most of which have been on the patella, with 10 femoral condyle procedures, and I've revised 1 case, and we'll talk about that later. The rehabilitation for my cases, I aim to do them all as a day case. I try and do them first on the list to get them home. They're all full weight bearing, whether it's a patella or a femoral condyle, with no limitation on the movement. We don't get a brace. We follow an enhanced recovery regime, which is the same as my joint replacements. They get DVT prophylaxis for 2 weeks, routine physio, and I tell the patients they're looking at a full recovery anywhere between 3 and 6 months, and that is very much patient dependent, like much of our elective surgery. In terms of discharge and follow-up, this is what we're moving over to now in the new sort of post-COVID world with digital technology, and we're really going to look at this app this one's from Zimmer Biomet. It's called My Mobility, and the patients can actually upload their own post-operative photographs of the wound, so we can do wound care. We can monitor how they're getting on with the physiotherapy, the range of motion. This is really something for these young, active, dynamic patients, it's something that we're going to be able to do. Perhaps in the elderly patients, the general arthroplasty population, this might be difficult with technology, but I think the young, active adults that we're talking about today, this is really something that we need to be looking at. So just to run through some clinical cases with you. This first case is one of my first patients from 5 years ago. She's a very active 47-year-old school teacher with a severe chondral lesion on the lateral facet of the patella, which you can see here on the axial MRI scan, and she was very debilitated with anterior knee pain and swelling. And really, she wanted a definitive solution for this. So we said, well, let's have a look and do a biopoly. So these are the intra-operative images, and on the far left you can see there the severe bare bone lesion on the facet. This has been reamed out, and then this is the implantation in situ there with a thin rim of cement, and you can just appreciate the recession there on the implant. You'll also notice the femoral trochlea is absolutely pristine over here. So this was a really good indication for the biopoly, and certainly not something I would want to do a patellofemoral replacement on. This is the same patient at 6 weeks. This is the wound. Obviously, it needs a full open incision so that you can invert the patella. But actually, the movement at 6 weeks for these patients is very good, and also they don't particularly get too swollen either. So this was the first case. When we took some X-rays and MRI scans later down the line, these are some images from 6 months. You can see on this X-ray the implant is very well incorporated with a sclerotic line around the patella. We call this the bullseye sign on the patella biopoly. And also on the T1 image on an MRI scan, you can see the implant is very well incorporated into the bone with no sign of loosening, and the knee is very quiescent and looks good. So it looks good on post-operative MRI. Second case, this is a femoral condyle case. And this guy was an engineer, almost 50, and he'd actually fallen at work about a year before, and it was a traumatic injury to his medial femoral condyle with significant bone edema. We tried to offload him in a brace. I thought I didn't particularly want to do an arthroscopy. I didn't think we'd find anything. There was no loose body in his knee. An osteotomy wasn't indicated because his alignment's good. There was nothing really to fix in terms of the osteochondral fracture, because you can see there it's still in situ. So we decided to open up an Optimum biopoly, and you can see this is the intraoperative slide here. You can see this is a guide wire where we've reamed out the diseased bone and the bone marrow edema. And then this is the implant in situ here. This is a 20mm circular biopoly press fit, again with the recession. And this case went very well. This is his post-operative image just before he went home. And unlike some of the other devices I presented earlier, you'll see that we don't really remove any bone with this device. It's very bone preserving. There's just a small peg which is grit blasted. This is a metal back, and obviously the biopoly doesn't project there. And this is the same guy at 6 weeks with a well-healed wound and very little swelling in the knee. We did have to take him back to theatre at 12 months when he presented with an effusion in the knee. And I was very concerned that he may have loosened the implant or what was going on here, but I was relieved to find that all he'd done, fortunately, with a twisting injury was tear his medial meniscus, and he just had a very small flap tear, which we sorted out with a day case arthroscopy. It gave us the opportunity to have a look at the implant. And you can see here that on the right of the screen, the implant's very well incorporated, and he's actually got some of his own cartilage, which is overgrowing the implant and almost looks like a normal femoral condyle. The other thing to notice about this patient is at 12 months is that the tibia is completely normal and intact. So it's clear that the hydrophilic polymer is not in any way impinging or irritating his tibias. That was good to see, and he's continued to do well. Our next case, this is a lady, quite interesting. She had a very complex history with this grade 4 medial femoral condyle lesion, and she'd been down the route of microfracture at various different hospitals. I think she's had 2 or 3 microfractures, and then she'd gone down to Stanmore, I think, in Middlesex for an ACI procedure. And she wasn't pleased with the results of that. She was actually on buprenorphine patches, quite fed up. Very bright lady who worked in administration, and she came to talk to me about the biopoly. And we used a bigger implant, a 24 by 15 millimeter racetrack implant, and you can see the device here in situ. And she recovered very quickly following this procedure. This is her image post-operatively. And you can see with the racetrack, it's got a double peg situation. It's very stable and well fixed. And when she came back at 6 weeks, she was very happy. She was off of crutches, and she was walking independently, and more importantly, she was off the morphine patches as well. And this is the same lady doing a single leg squat at 6 weeks.
Yeah, okay. Good. Okay.
This one on you to do with it.
Okay. Yeah, you're doing great.
So that was a good case. Now this guy, this gentleman was a much more active and dynamic individual. This is a case from last year, and I've done a microfracture on him 12 months prior to that. I think it was February 2018. But he was an Ironman wannabe, and really sort of into his triathlon and his training. And he came with a large medial femoral condyle defect, and we did the same procedure for him, again, day case procedure. And he sent me an email 6 months down the line, so in October of last year, and he just completed the Marrakesh half Ironman, and you could argue that this guy would do well whatever operation you did for him, because he's that sort of guy. But it just goes to show, you know, we can get really good results with this implant, and it tells me now it feels like he's got a normal knee. Now another case to discuss. This is probably a selection problem of mine. One of my early cases from 2015, and she came to me with this MRI scan and bare bone on the medial facet of the patella, and it was quite awkward because it was extending towards the central patellar ridge, but a trochlea was intact, and I was reluctant to do a patellofemoral replacement on her because she's a gym instructor. And when we opened the knee, you could see quite clearly the trochlea was completely normal, but the whole of the patella was really involved, and this is more what I would describe as a chondromalacia with significant softening throughout the medial facet here and also the lateral facet. And I decided to do a double implant. This is 2 15 millimeter implants on the patella at the time, and it wasn't really within the indications of the procedure, because at that stage we'd only done single facets, but I thought that it warranted it. Post-operatively, she looked to be doing quite well, but then we saw on a post-op X-ray actually she was beginning to develop some medial compartment arthritis as well, and some recurrent effusion in the knee. So I sent her off for an MRI scan, and you can see quite clearly the medial compartment was pretty worn. This is the beginning of last year, and she's now got bare bone within the medial compartment. And interestingly, on the axial on the MRI scan, you can see the original implant on the medial facet is very well fixed with no high signal around the implant, but unfortunately the lateral implant was loose, and you can see that with the bone edema. So if you do have a loose biopoly, this is what you may see, and perhaps I was extending the indications too much here. So 4 years after her initial operation, we had to convert this to a total knee replacement. She's doing well with that, but it's not an ideal situation, and you may argue, you know, we should have done that in the first place, but that's a very difficult decision to make in a 40-year-old with bicompartmental arthritis. Just a couple of other cases to finish before we move on to the results. This is a 39-year-old hairdresser who came into me with severe patellofemoral arthritis, with night pain, but also a small lesion on the medial femoral condyle. So we have done a couple of cases where we've done a combined biopoly and patellofemoral replacement. This is a Zimmer biomat implant with a 15mm medial femoral condyle defect, and these can do well. This is just a case for discussion, really. This is another patient of mine, a medial femoral condyle implant 20mm. Is a guy, very active guy, another engineer, and he's actually very happy with his implant, but he was on surveillance as part of a trial, and we'd x-rayed him, and we saw a lucent line under the implant on the lateral projection, which I was a bit concerned about. But there's been absolutely no progression of that line, and he remains very well and very happy with his surgery. So whether or not this is an element of stress shielding, I don't know, but I spoke to the radiology guys about it, and they did an MRI scan, and you can see from the MRI the implant is very well fixed. There's no bone edema, no fluid, and perhaps this is just a phenomenon of having a metal-backed implant, a little bit like we see in some of the unicompartmental knee replacements on the tibial side, and even some of the total knees. So it's just something to look out for and be aware of. So moving on to some of the results. So far, worldwide, there's been close to 850 implantations now, mainly in Europe. The early data has been published in the Journal of Bone and Joint Surgery back in 2017, which we'll talk about later. And the longest term patients are now out to 8 to 9 years. And so far, the overall revision rate out of those 800 cases is less than 2%. The current ongoing studies, there's an ongoing study with the femoral condyle implant, with results now out to 5 years, which is great, and a newer patella study, which I'm personally involved with results out to 1 year. The femoral condyle study was set up over 5 years ago now. It was a multi-centre study, with those centres listed there at the bottom of the slide, and initially it was a study to compare the clinical outcome between biopoly and what was then a gold standard of microfracture, looking at pre and post-op scores at 2 years. And this cohort of patients, which is 35, has now been followed up to 5 years, and we'll just have a look at those results. So this is the comparison to microfracture. You'll see there on the right of the side, on the right-hand side of the slide, there's very favourable scores from pre and post-op for the biopoly when compared to some of the historical microfracture slides, when you look at the difference in pre-op and post-operative scores of the COOS. So that's quite interesting work. And when you look at the clinical data, the clinical results, and break down the COOS scores, you can see that these scores are maintained out to 5 years throughout the whole range of the scores, and the same can be said for the pain scores as well. This is the same cohort out to 5 years, and also the Tegner score as well from the preoperative statement up to 5 years. So the implant seems to make a big difference, particularly within the first 1 to 2 years, and then those benefits are sustained. The patella study, I'd just like to talk about. There's 3 UK centres that are currently recruiting. There's Dinesh down in London, myself, and Bristol, and we're aiming to enrol 35 patients, of which we've now got about a dozen patients in the cohort. We're collecting scores as we go along. It's a prospective study. And so far, again, the results look good. So very similar to the femoral condyle. These are results out to 1 year, and the COOS scores seem to be improving between 6 months and 1 year. The pain scores, very, very similar picture to what we saw previously in terms of the improvements both at 6 months and 1 year. And again, the Tegner scores and the Kajala scores very similar. Just some new developments. There's now a biopoly trochlear implant which has been developed. I was fortunate to help out with the design of this implant. So far, there's only a couple of these gone in, but certainly for these very difficult lunge type lesions that we do see, this offers us a different option. And there's 3 different shapes available in terms of the shape of the trochlea, which we can measure on a preoperative MRI scan. And I'm looking forward to doing a couple of these cases later this year. The current agenda, we're opening up a visiting surgeon program for surgeons that are interested, and we're going to try and collect more data on using the Pro1 platform and really gather as much data as we can in terms of a register for all of the biopoly implants that we do. But we do need to bear in mind the hype cycle when we think about new technology. I mean, I'm 5 years into this technology now, and I have to say I'm very confident with it. I think if we would have seen early problems in terms of loosening and infection, we would have already done so, and I've just not seen that in my 30 patients. But we do need to bear in mind this, new technology and the way it's introduced. But if it's introduced safely with adequate surgeon training and volume, then I do think it's a good option for our patients. There's some discussion areas regarding coding at the moment. We're coding the surgery as a unicompartmental knee replacement, or a W5200. There are some concerns regarding congruence with the femoral condyle implants. I've not seen that problem myself, but we are in the stages of developing a total condylar replacement to resurface the whole area, which should negate that concern. There's certainly issues regarding surgeon volume. It's nice to be doing at least 12, 15, 20, 25 cases of certain procedure each year. And I think ideally surgeons should be doing at least 1 case a month, ideally. And hopefully by collecting data in terms of a national register, that will help us develop the product and the surgery even more. We're also going to start adding these cases to the National Joint Registry as of next year. So in summary, I think the instruments are excellent. It's a reproducible technique, and it certainly fits into our ethos of joint preservation and accelerated recovery. And the results so far have been good with, as I said, less than 2% revision rate for those cases. I'd just like to finish on a positive. So moving into 2021, I think we're coming out of the worst of it now, and I think out of all of these problems that we've faced, we certainly can take some opportunity, and there's great opportunity to be improving patient pathways and streamlining care. And certainly I've seen it in my own practice in the last 3 months, doing telephone and video consultations with patients and really try to speed up the pathway with virtual follow-up and that type of thing. I really think something good can come out of this crisis. And